Alright, welcome back guys. So last time in Renal we did a good discussion about kidney stones. We figured out mnemonics and visualization methods of really how to memorize what the pH would be for every kind of stone to precipitate and what they look like, right? What the crystal actually looks like. And that was a pretty good video right there because memorizing pH was actually really easy if it had phosphate in it. If the stone had phosphate in it, then you just remember, when you write phosphate, you write pH twice. So all the phosphate stones have high pH. So ammonium magnesium phosphate and calcium phosphate. The others all require a low pH. And then there were some key things we talked about, like the hypocitrate urea was significant here. Uric acid stones are very high yield, pops up all the time, right? And all the associations that you need to know about. And then cystine stones, which are probably the easiest one to get questions on, right? We added some extra pictures, looked at all of them, discussed all of that. That was pretty good. Now we're moving on to a couple of easier topics, and then a big one about urinary incontinence, right? So urinary incontinence is the third biggest topic that gets discussed in renal after the nephritic nephrotic syndrome stuff, after the kidney stones, all right? So after we look at urinary incontinence, the fourth big major topic about renal is basically just kidney injury, right? So we're going to start looking at pyelonephritis and acute kidney injury. So that'll probably be the end of it, and we'll be done with renal. So let's get this started. So first things first, hydronephrosis. We've talked a lot about hydronephrosis so far, especially when we started renal. We also saw hydronephrosis sometimes in endocrine. Right? So there's many scenarios where you can get hydronephrosis, and it's usually something that you can fix. You can get the hydronephrosis to go away if you remove the underlying issue. So they tell you it's a distension or dilation of the renal pelvis and calluses, usually caused by urinary tract obstruction, such as a stone like you see in this picture here. Could also be because of severe BPH, congenital obstructions, cervical cancer, or an injury to the ureter, especially after some kind of surgery as well. Other causes include retroperitoneal fibrosis, vesicoureteral reflux. Now, those two are lower yield answers, but I think one of these is actually a question where the answer was about retroperitoneal fibrosis. So it is worth remembering, that your ureters are retroperitoneal. That is something that you have to keep in mind. It is part of the SAD pucker. And vesicoureteral reflux is something that we're going to see again soon too. Dilation occurs proximal to the site of pathology, right? Which makes sense. So if you have an issue here, proximal to that, everything else is dilated. After that pathological area, everything is normal or thin. Serum creatinine becomes elevated if the obstruction is bilateral or if the patient has an obstructed solitary kidney, which is a big hint for you, right? So if you see no other renal issues in a patient, their kidney function is okay, they simply have hydronephrosis, maybe because of a kidney stone or any one of these other issues, and their creatinine is high, that usually tells you that it's probably bilateral or they only have one kidney. So that's a important thing to keep in mind. Leads to compression and possible atrophy of the renal cortex and the medulla. And then we have these two practice questions here, so let's take a look at them. The one up here is from Ambos, and this one's from UWorld. So the Ambos one says, a 2-year-old girl with recurrent urinary tract infections is brought to the physician for a follow-up examination. Renal ultrasound shows bilateral dilation of the renal pelvis. Avoiding cystourethropy shows retrograde flow of contrast into the ureters during micturition. Histologic examination of a kidney biopsy specimen is most likely to show what findings. Now, they used a couple big words here, but there's really nothing to be confused by. Micturition is just urination, basically, the whole process of urination. And cystourethropy, eniography, they're just exploring that area, right? So they're checking out the bladder and stuff. And when they did all of this, they saw that there was retrograde flow, right? The retrograde flow of the contrast into the ureters. So something's not correct here. And then the answer choice that was correct for this was cortical thinning with tubular atrophy. Why would you see that? This is seen in patients with hydronephrosis, right? Cortical thinning with tubular atrophy is another thing you can see in patients who have hydronephrosis, and it totally makes sense. Chronic retrograde urine flow increases pressure within the nephron lumen and subsequently compresses adjacent blood vessels. Decreased blood flow through these vessels results in decreased renal perfusion and eventually atrophy of the renal cortex and medulla. Serum analysis in this patient will most likely show elevated serum creatinine levels as both kidneys are affected. Hydrostatic pressure in the tubules will be elevated, which is another thing that can be an answer choice. Right, so this is a pretty simple, straightforward question about a more pediatric case. Here is a case with an adult from the URO question. So they say a 46-year-old woman being evaluated for irregular vaginal bleeding is found to have invasive cervical carcinoma. She undergoes total abdominal hysterectomy and bilateral salpingo-oophorectomy. Pelvic lymphadenectomy was also performed, during which several enlarged nodes around the pelvic vessels were resected. A week later, the patient experiences left-sided flank pain that radiates to the groin. Her temperature is 97, blood pressure is fine, and pulse is okay. On physical exam, there is a palatable left flank mass. Right, and here is another weird word, right? Palatable, that many people would not know what that means. Which of the following most likely accounts for this physical exam finding? And turns out that the question is literally about the word, you might not know what it means. So the answer here was just hydronephrosis. Her flank pain radiating to the groin with a palatable mass suggests ureteric obstruction. The ureters are in close proximity to the pelvic vessels, so they are vulnerable to injury. And she did undergo a bunch of different procedures. Unintentional ureteral ligation causes obstruction with hydronephrosis and flank pain due to distension of the ureter and renal pelvis. So all in all, the main thing is to understand, if the question gives you a scenario where hydronephrosis is possible, pick the answer choice that's most relatable to the hydronephrosis. Right, and there are many scenarios where hydronephrosis can be plausible, and the first thing you have to look at is the age, right? Once you are, and that's usually the first thing that's in the question. Once you get that age down, you can knock out some of these. Like, for example, someone really young will not have BPH, for example, right? Someone really young doesn't really have much cause for a renal stone unless the question told you something about why they have renal stones. So if you do get a question, now we just did renal stones in the last video. If you do get a question about someone having excessive renal stones at a very young age, that's more cause for you to believe that the answer might be hydronephrosis, right? So usually, it's never really a difficult topic to pick. If you do get a question on hydronephrosis, it's usually pretty clear, right? And as step one moves on forward and forward as the years come by, answer choices are becoming more confusing than just hydronephrosis. So that's the difference between UWorld and AMBOSS that I really enjoy. Like UWorld, the answer was just hydronephrosis, right? Which is very rare on step one. AMBOSS had a much more physiological answer choice, right? A pathophysiological answer choice rather than just putting hydronephrosis, which is something you probably figured out from the question anyway. And just to take a look at this picture one more time, so you can see here you have the calyces, the pelvis. It's all much more distended than the normal kidney, right? And even the minor calyces you can see is kind of going into here, right? So it's still, everything's backing up. Everything's backing up, and that's causing things to swell up, and it's really problematic. And this kidney stone, if it does eventually start going down the ureter, that can cause bleeding. That can cause the flank pain that you get in questions. So those are things that you would see in your question stem. And this is just another note here. They didn't put it in the answer choices. I mean, in the explanation here, that pregnancy is another thing that can cause hydronephrosis. So you have to keep that in mind too, right? The gravid fetus can actually compress ureters at the linea terminalis, and that can also cause urine to flow back, and that's the backwards retrograde flow they're talking about here. So if urine can't pass down here, it's just staying here, and that's also going to cause hydronephrosis. So you have to be ready with that answer choice as well. In the middle here, they talk about renal cell carcinoma, which is another very big topic, and it's very important to remember what renal cell carcinoma is actually directly related to. So renal cell carcinoma, you are going to see polygonal clear cells filled with accumulated lipids and carbohydrates, and that's kind of what they're showing you right here. So they're polygonal, they are filled with lipids, which is why they're also white, and the nucleus is pushed to the corner. Often golden yellow due to a high lipid content, which is what the gross image here is showing you. Originates from the PCT and invades the renal vein, which is the most important thing to keep in mind, right? So if your question is about the renal artery, right, then it's not a renal cell carcinoma question. That's something you really want to keep in mind. Renal cell carcinoma invades the renal vein, something that can really help you figure out your answer choice if you just keep that in mind. Because from there, then it can cause development of a varicocele, right? So if you have a patient presenting because of a varicocele, it is possible that they might have renal cell carcinoma. And after invading the renal vein, it goes into the IVC and causes hematogenous spread. And you have to remember that, blood in your veins, that goes back to your lungs, right? Because blood in your veins is deoxygenated. Now it has to go back to your lungs to pick up more air. So renal cell carcinoma can actually metastasize to the lung. Right, so that's another very important thing to keep in mind. They love pathology questions. Step 1 loves asking pathology questions about renal cell carcinoma, which then metastasizes to the lung. Very rarely is it going to be a question about bone. It can be though, but usually going to be something about metastasizing to the lung. And then when it goes to the lung, right, then it can cause any of these other paraneoplastic syndromes. Right, you can have a lung cancer that can either release PTH-related peptide, EPO, ACTH, renin, right? Any of these other things. So you have to remember these associated paraneoplastic syndromes. Any of these can actually be another secondary reason they presented in the clinic in the first place. Now, as far as types of renal cell carcinoma are concerned, I haven't really seen many questions asking about the types of renal cell carcinoma, but clear cell is usually what we have to remember, right? So clear cell is the most common subtype, and it's associated with the gene deletion on the chromosome 3, which also reminds you of the 3 letters for not just renal cell carcinoma, but VHL. VHL is also 3 letters, right? So it can be because of sporadic or inherited VHL syndrome. Also remember, bone metastasis for renal cell carcinoma and almost any of these guys can present with osteolytic bone lesions. When we did musculoskeletal, we talked about how one of the major things to remember was whether the bone metastasis is osteolytic or osteoblastic. That's usually a big giveaway for what's happening and where the cancer is coming from. So here for renal cell carcinoma, if it does go to the bone, you're gonna note osteolytic bone lesions. Now, how is your patient going to present? So manifest with hematuria, palpable masses, secondary polycythemia because of the excess EPO production, flank pain, fever, and weight loss. Weight loss almost always presents with any kind of cancer anyway, so that's something that's often a really big giveaway. And then in the end, once you actually figure out that a patient has renal cell carcinoma, what do you do about it? So treatment, generally speaking, surgery or ablation for the localized disease, immunotherapy like aldesleukin, or targeted therapy for any metastatic disease. And this is rarely curative, which basically means that if you have renal cell carcinoma, first things first, your kidney is only going to get worse and worse. So your kidney will not be something you can just fix and repair. And it's very resistant. You can see resistant to chemotherapy and radiation therapy. So things are only going to get worse. And then if the metastasis is really bad, then the patient will probably die. Right? If the metastasis is not that bad and treatment can be done for that, then go ahead, you do the chemotherapy and whatever for that part. And then removing the kidneys is very important. You get the kidneys out of the body before more metastasis occurs. And this is renal cell carcinoma, clear cell renal carcinoma especially, is the most common primary renal malignancy. All right? It is associated with smoking and obesity, which is pretty much a giveaway, obvious thing, nothing crazy there. Now this image A is the one that they gave you to show you the polygonal clear cells. Here is another slide showing renal oncocytoma, so that's going to be something we're going to look at later, so don't confuse this picture with any of this stuff here. Right, so this is the only thing you need to remember. If you get pictures like this that look like fat-filled, carbohydrate-filled, big plump cells, and they're talking about the kidney, it's renal cell carcinoma. This was just a very basic question from USMLE RX. So they tell you a 58-year-old former smoker presents to your office with weight loss and hematuria, right? So the weight loss is a sign for cancer, hematuria is a sign for something being wrong with the bladder or kidneys. When you listen to his heart, you note a prominent systolic flow murmur that is new to his exam. What is the likely diagnosis? Without even listening to the heart, the most likely diagnosis here was between either renal cell carcinoma or bladder cancer, either one of those two. The heart part, right, tells you that this guy probably has excess EPO production and he has too much blood in his body, which is why he's getting a systolic murmur. It's just a flow murmur and is during systole when it's actually contracting. Right, so you would just pick renal cell carcinoma based off of that and move on, even though not enough solid information is given to diagnose renal cell carcinoma. Right, and that's not the point here, though. Right, your questions are not there to help you diagnose something. Your questions are there for you to be able to come down to your most likely diagnosis, and then order tests and figure out a diagnosis and move on in life. The last thing on this page is a question about the topic of renal oncocytoma. Very rare topic. I haven't really seen too many questions on it, but it is pretty cool, right? Because it has a lot of stuff happening. So this is a benign epithelial cell tumor arising from collecting ducts. Okay, very important to remember that part too, because you can get questions where they ask you about the collecting duct part of it. And arrows here in this one are showing you that circumscribed mass with a central scar. So this is pretty significant because renal cell carcinoma, the NBME especially loves giving you gross images, but step 1 can also, and the step 1 pictures are usually much better than the NBME pictures are. So if you get a question with an image like this where it's well circumscribed, that can't be renal cell carcinoma. Right, because renal cell carcinoma is not circumscribed to one area, it's everywhere. Right, but this is very well circumscribed. It's in one area right here. It's epithelial and it's from the collecting ducts usually. You're going to note large eosinophilic cells with abundant mitochondria without perinuclear clearing. Right, so that's showing you in B the oncocytoma part versus the background tubules. Right, so two different parts of the same stuff. Large eosinophilic cells with abundant mitochondria without perinuclear clearing, presents with painless hematuria, flank pain, and abdominal mass, often resected to exclude any malignancies such as renal cell carcinoma. Right, so just in case this gets worse, you just resect it. And generally speaking, you can't really do anything else with this anyway. Right, if it's looking like this, just take the kidney out. So this left half of it is the oncocytoma. Right, and there's something else called a chromophobe renal cell carcinoma, which is a potential differential, but the book doesn't talk about it at all. So that's something that you would go ahead and just, Google real quick, check it out. But a chromophobe basically means it doesn't stain. Like this is staining pretty well here. And this image is also showing you a really good picture of what's happening. Right, so this is a slide showing renal oncocytoma. It will always be described as a well-defined mass in the kidney. Very well-defined. And you can see how big some of these cells are. Right, and there's a lot happening in them, but there's nothing, they're very different. There's nothing here for you to pick renal cell carcinoma because they're very different from it. These cells are not full of fat. Right, renal cell carcinoma, the cells are full of fat and carbohydrates. Here, they're just very eosinophilic and they have a lot of mitochondria, which you won't necessarily see on an H&E stain. Okay, and this is actually a question related to the same page here. So this one says, a 63-year-old man is being evaluated for fever, anorexia, and discomfort associated with breathing. He has a history of frequent and extended travel to sub-Saharan Africa. The patient has never had regular medical care due to his extensive traveling, so his medical history is unknown. Radiologic studies of the chest show multiple round lesions in both lung fields. Lab reveals a hematocrit that's higher than normal. Biopsy of the lesions reveals a slide just like image A. So this one right here, of renal cell carcinoma. What is the most likely primary location of this patient's metastatic disease? Right, so his metastatic disease is in his lungs bilaterally, and clearly he has some kind of excessive EPO, secondarily high EPO, and then they also gave you this histological image that you may or may not remember, and that's where your answer comes from. When you see that histological image and it looks like this, you should it should ring a bell for renal cell carcinoma. And then even if it didn't ring a bell, you look at your answer choices, right? You look at all your answer choices, and try to see which of those answer choices is related to a histological image like that. As soon as you see kidneys, you can come up with the story for that to be a valid answer, and it should work, right? Most likely, this guy has renal cell carcinoma, which has metastasized to both of his lungs, and now he's just, not doing too well. He's getting worse. The rounded and polygonal cells with abundant clear cytoplasm tells us he has clear cell carcinoma, the most common subtype of renal cell carcinoma. The cells are full of glycogen and lipids, so they appear golden yellow macroscopically, or gross, on gross image. Erythrocytosis and polycythemia may occur due to constitutive secretion of EPO. Renal cell carcinoma is often detected incidentally, so it is common for the metastasized neoplasm to be discovered before the primary neoplasm. And that's something you really have to keep in mind. Step 1 loves questions where they can shift gears, right? So a question might start with an x-ray, right? They talk to you about some kind of lung finding. They'll describe a history of smoking or something. And then all of a sudden the question shifts gears to something renal related. Right? So very important to be able to understand the connections there, otherwise those shifts won't make any sense. These two topics are also very high yield, very big topics. We talked a little bit about nephroblastoma before. This was also a really big topic related to endocrine, right? It's a big topic there too. And then the next one, transitional cell carcinoma. So let's look at nephroblastoma first. This is also called Wilms tumor. This is the most common renal malignancy of early childhood. Contains embryonic glomerular structures, presents with large palpable unilateral flank mass and or hematuria and possible hypertension because of the excess renin. Loss of function mutations of the tumor suppressor genes WT1 or WT2 on chromosome 11. I can always remember chromosome 11 because you have one kidney on each side, so 1 in 1. And then WT1 and WT2 just stands for Wilms tumor. Alright, so now they added a couple extra things here in first aid 2019. They kind of made it unnecessarily weird. I don't really think I've ever seen a question about the WGR complex, the Dennis-Drass syndrome. I've heard of Beckwith-Wiedemann syndrome before, but not really in a question. So, they really want you to, I guess, know that there are these breakdowns for nephroblastoma. First things first, you should be able to identify it in an image like this. If you're ever given an image like this and you see something like that, that's nephroblastoma. Okay, it's one portion of the kidney that's gotten really big, really dark, right? And there's a lot of stuff happening in there. That's a nephroblastoma. Usually the kid age will also be very significant to help you figure that out. Right, whereas in renal cell carcinoma, there's actually issues inside the kidney, right? Not that something big is growing out of it. So very important to remember that too. Now, these are loss of function mutations, and they may be a part of several syndromes. Note that WJR is a WT1 deletion, while DD is a WT1 mutation. Right? And they made that very clear. They wrote that here. Because of a WT1 deletion, you can get the Weiger complex. If you have a WT1 mutation, generally a loss of function mutation, you get Dennis-Drass syndrome. So what are these? The Weiger complex is a compilation of these issues. It's Wilms tumor with absence of the iris, aniridia, genitourinary malformations, and mental retardation. Right? So Weiger, Wilms, aniridia, GU issues, and retardation. Very important to remember that. Dennis-Drass syndrome is Wilms tumor with diffuse mesangial sclerosis, dysgenesis of the gonads. Right? So this dysgenesis of the gonads could actually be the primary reason for presentation. A man might come in saying, I am not really able to produce or something, not really feeling much like a man or whatever the issue might be. And then from there, it might lead to other issues. The next thing, Beckwith-Wiedemann, this has the Beckwith-Wiedemann. So the dash helps me remember there's two things, so WT2. Beckwith-Wiedemann syndrome is Wilms tumor with macroglossia, organomegaly, and hemihyperplasia. Basically, everything's really big here. So I always remember this as Beckwith-Wiedemann. right? So wide would remind you of everything being really wide, macroglossia and organomegaly, wide. Right, so these are not the worst things to memorize, but you do have to spend a couple minutes trying to make sure you can get it down, right? So Wagner complex, WT1 deletion, Dennis-Drash deletion. That's what, it's, sorry, what was I saying? Dennis-Drash is the one that's got the WT1 mutation, excuse me. What was the thing for, oh, yeah, Dennis-Drash dysgenesis, right? That's what you want to remember, Dennis-Drash dysgenesis, right? Because this is, the unique thing in Dennis-Drash is the dysgenesis of the gonads. They all have Wilms tumors, so there's no confusion about that. They all have a Wilms tumor in it. It's what else they have that helps you differentiate one answer choice over the other. Wagner complex, the cool thing or the unique thing here was the aniridia. Dennis-Drash has the dysgenesis of the gonads, and Beckwith-Wiedemann is wide. Right, everything's big. Organomegaly, macroglossia. I also had to hear from UWorld that Wagner and DD are an issue with the zinc finger transcription factor, crucial for renal and genital development. Both will have nephrotic syndrome, but Beckwith-Wiedemann will not. Okay, so that could be something that might be able to help you pick the right answer choice. Men 1, by the way, this is also something you have to keep in mind because chromosome 11 is involved here. Men 1 is due to a menin gene issue, which is also on chromosome 11. So think of the M and W being written with two vertical lines first, reflecting 11. Okay, so just like when you write M and when you write W, right? So let me see. So you can just think of like writing M, right? You have to make two vertical lines, right? And the same thing with W, right? So that's basically all I'm talking about there. Not the most significant thing, but if it helps you, then that's great. All right, so that's nephroblastoma, Wilms tumor, pretty big topic. These are the lower yield subsections of Wilms tumor. Thinking that he may have had a helmet infection from his trip to... Oh, yeah, that's right. Yeah, this guy, he doesn't have an issue. This 63-year-old man, he has renal cell carcinoma, and his issue is just something that occurred. It just happened. It could be because of something else in his life, but it's not. That's not what S hematobium is. Right, hematobium is related to bladder cancer. So that's the next topic, right? Transitional cell carcinoma, as well as squamous carcinoma of the bladder. So the squamous carcinoma of the bladder is the one that's due to schistosoma hematobium infections in the Middle East, chronic cystitis, smoking, chronic nephrolithiasis, and this presents with painless hematuria, right? There's no flank pain here or anything. So that's a giveaway for something related to the bladder, whereas if someone has hematuria and flank pain, that's an issue with the kidney or ureter. And in this question up here, they did mention going to Africa because I'm pretty sure one of the other answer choices was bladder, right? So that is a confounding factor that they throw into questions to really confuse you. But the histological image like this one was what's really critical for getting the correct answer for this URL question right there. So the histological image for transitional carcinoma, transitional cell carcinoma, is going to look like this. Basically, what you're going to see is epithelium that's not very clear. Right, so because it's transitional epithelium, it's epithelium on top of epithelium, and what they can do is they can expand, right? So they become very, very thin as the bladder fills up. This is also called urothelial carcinoma. It's the most common tumor of the urinary tract system. Can occur in the renal calyces, renal pelvis, ureters, and bladder. Right, so very important to remember that transitional cell carcinoma doesn't occur only in the bladder. Okay, can be suggested by painless hematuria, and there's going to be no casts associated with problems in your PSAC, phenacetin, smoking, aniline dyes, and cyclophosphamide. Now, all of these are things that do pop up, right? These are all probably things you've done questions about on UWorld already, especially the aniline dyes, especially cyclophosphamide. Not so much phenacetin, very rare. Phenacetin, also called acetophenetidine, right? Weird names, but phenacetin is basically a pain-relieving and fever-reducing drug which was widely used between its introduction in 1887 and 1983, right? And then it was banned by the FDA because it was causing transitional cell carcinoma. And how scary is that? Right, so for all that time, this new medication that was put into the market was leading to bladder cancer to patients. So when new medications come out, it's always pretty scary, right? It's always pretty scary. Regardless of how much research might have been done, many medications don't actually lead to some really, really bad adverse effects until much later on. So that's phenacetin. So if you got a weird question about someone taking some medication that you've never heard of, right? And it's just for pain or fever. And now they have bladder cancer. Is going to be phenacetin, but this is almost never in questions anymore because it's a banned drug now, so you don't really find it anywhere. Aromatic amines, right? Aromatic amines or aniline dyes, like benzidine, are also critical risk factors. Watch out for associations with rubber production, oil refining, and dye making industries. Nicotine and arsenic, as well as platinum based chemotherapeutic drugs like cisplatin, also play a major role. And if you've done your chemotherapeutic drugs from the cancer section, you know a lot of them were related to the bladder as well. Right? Smoking is obvious, and then cyclophosphamide. Now, cyclophosphamide is avoidable. With cyclophosphamide, you can give Mesna as a medication too, and if you prescribe Mesna with cyclophosphamide, the chances of you getting bladder cancer or transitional cell carcinoma because of the cyclophosphamide becomes significantly lower. Okay, so it's not going to happen. So anytime you have to give someone cyclophosphamide, also give Mesna. Here I wrote urothelial carcinoma of the renal pelvis or calces will be pedunculated, right? Which is probably some description I read in the question, so I made sure I added that here. Right, but generally speaking, you can already see it's a very papillary tumor. So pedunculated, papillary, it all means very like finger-like. There's finger-like extensions coming out. Right, these are descriptions that they love using. And the squamous cell carcinoma stuff, chronic irritation of the urinary bladder leads to squamous metaplasia, very similar to how you get Barrett's esophagus, and then that leads to dysplasia and squamous cell carcinoma. Right, so chronic irritation of the urinary bladder, and that can be due to any of these things. Right? Chronic nephrolithiasis is also bad. So if you know someone has kidney stones over and over, you need to stop them from getting more kidney stones, not just fix the kidney stone issue itself. All right. So I'm going to stop this video here and do urinary incontinence as a separate video because it's actually a really big topic. So I'm just going to take a 5-minute break and I'll be right back to continue urinary incontinence.